The title of my presentation is Health System Resilience Capacity in the Federal Context of Nepal, Findings from the Mixed Method Study. You can see the list of the authors, and my name is Shreeman Sharma. I'm one of the contributors. So I would like to start with some of the concept around the health system resilience found in the existing body of the research, primarily focusing on 3 points around health system resilience. So health system resilience is a concept that is primarily associated with the strength of health system. And first is, health system can be strong in the stable condition, but it doesn't mean that even the strong health system may not respond very well. On the other, poor performing or underperforming health system in the normal circumstances can even perform better. So health system resilience is not very straightforward. And the third point is health system resilience is associated with the strength of the system itself. And it is ongoing process. So this notion closely links with the objective of our research in the Rebuild for Resilience project. Rebuild for Resilience is the multi-country research project, and HORD International is one of the partner, and the study is implementing in Nepal as well. So this is the guiding framework of our study, and in the interest of time, I'm not going to elaborate it. So there are many objectives in our study, but particularly the study I'm presenting here aims to map the resilience capacity of the local health system. And largely, our study is focused in one of the municipality in the Kapilvastu district of Lumbini province. We call our study site as a learning site. So as a method, we have employed a mixed method in our study that includes the review of different policy documents and consultative meetings, KII with ranges of the stakeholders. That includes local health system stakeholders, especially the policy actors, health workforce, and close to community workers, as well as the representatives from the non-public sector. And we have also gained some insights from the secondary data, especially analyzing the disaster record from 2017 to 2023. And we also conducted health facility assessment in 13 health facilities of that particular municipality. And we also gain insight from the minimum service standards assessment as well as routine data quality assessment. So the results are here, but before presenting the results, one of my fellow colleagues who is sitting behind suggested me to put forward a disclaimer with the audience, and the disclaimer is that we have become a bit critical in presenting the findings, but take it as a neutral findings, because the objective of our research is to identify the gap, and whenever we present the gap, sometimes it looks a bit critical, so apology for that. So this picture illustrates the risk of different districts in terms of the hazards, and you can see the most of the districts which are located in the hilly area and tri-belt, southern part, they are more vulnerable from the perspective of hazard. And you can see here Kapilvastu district somewhere here. The Kapilvastu district is moderately vulnerable in terms of the incident count as well as the economic loss. But when it comes to the death, so it has high risk. So this provides the national picture and illustrates the hazard risk by the district. You can see the majority of the district have the moderate disaster risk. But there are a few of the districts which are at very high risk, both from the perspective of economic loss as well as from the mortality perspective. So these are some of the common shocks that we found in our learning sites. And we have categorized different types of shocks that we found during our study. The first type of shocks was the short kind of shocks that included the vehicle accident, short outbreaks like measles, eye infections. And second, also the long-term shocks like COVID-19. And then we also found the seasonal shocks like floods, inundations, fire, displacement, seasonal diarrheal disease outbreak, which we have listed as the short repeated shocks. And we also found different stressors like climate change, increasing burden of NCDs, and unchecked border crossing as a chronic health system stressor. And we also found some of the factors like resource poor setting, poor linkage between information system and planning, as that makes the health system dysfunctional. In the domain of human resource for health, we found that there was a mismatch between demand and supply. For example, in one of the health facility that where we found that 2 health workers were catering to the needs of 9,000 population, but on some other health facilities, same number of the people were serving very less number of people compared to this number. And the unfulfillment of the sanctioned position has remained also as a major problem. And another is the capacity. Given the constitutional right, the local health system have been given, or the functions they are entitled to, there have been gap in terms of the leadership, governance and management. And another area is the motivation when it comes to the human resource management. So we found that in our learning site, the conventional way of rewarding people and providing incentive was quite common, but intrinsic motivations, for example, like providing the job placement in their preferred positions and providing them exposure, were very instrumental to motivate their staffs. Here are some gaps in 4 areas. One is the constitutional power without capacity. Capacity is something which is frequently raised because local government have been overwhelmed with the autonomous right they have been given, but they lack the capacity. And another important aspect is planning role with a limited decision space, because local health system is overwhelmed by the programmatic activities from the federal government, and they have limited planning roles. And on the financial aspect, 2/3 of the budget goes as a conventional grant, which has to be spent as detailed out by the federal government. So there is limited space for the local government to have flexibility in the budgetary arrangement. In the interest of time, I'm going to tell you 2 stories which are very important from the perspective of health system resilience. Coordination and collaborations, which is repeatedly cited everywhere. So this is not just a fancy terminology, but very practical when it comes to serving the people. So here is an example. So in the learning site where we work, municipality thought that if it spent 10 million rupees for the installation of oxygen plant, then people will get service from there very easily. And they allocated budget for the installation of the oxygen plant in the hospital, previously we called district hospital. And the hospital falls in the jurisdiction of the Lumini provincial government. And Lumini provincial government did not provide human resource, and even the lab facilities were poor. And ultimately, the people from Kapilvastu had to travel some 50 kilometers away from their hometown, right? So sometimes coordination, seems very fancy term, but it has implications to the life of the people. That's why that is something that I want to convey from this story. And another story, when the whole country was grappling with the COVID-19, and of course, the local health system had pressure to respond the pandemic as well. So municipal office decided to use the schools for quarantine during COVID-19 pandemic. But unfortunately, school did not have wash facilities, including toilet and drinking water, right? And quarantine program was not effective and disease spread rapidly. The message is very clear. The notion of multi-sectorality has been missing somewhere in the local health system. So that is very crucial for health system to be resilient. So here are some conclusions that we have drawn from this study. Of course, the first is there are several areas of improvement for the local health system, for example, in the area of human resource and routine information system, as well as surveillance and leadership and management. Second is, of course, local government are autonomous. There is high degree of autonomy, but at the same time, there are limited flexibility as well. And third, so even if the local government has resources, or even human resource, it alone cannot be resilient until and unless there is coordination among three-tier government, as I previously demonstrated in a previous slide. And finally, the notion of multi-sectorality that was largely missing in our learning side, which is very crucial for the health system to be resilient. Thank you.